My second topic is pressure support ventilation. Pressure support ventilation is also known as the assisted spontaneous ventilation, where it is a method of weaning of from ventilator, and it is a spontaneous mode of ventilation in which each breath is a patient triggered, and the ventilator delivers a preset positive pressure during inspiration to assist in breathing. And it is a the pressure support ventilation is started with a pressure of 5 to 15 centimeter of water to augment the spontaneous tidal volume to until the desired tidal volume and respiratory rate is reached. uh, this method became popular since the patient need not be disconnected from the ventilator, and the pressure support can be gradually decreased when the patient generates adequate tidal volume. The patient can be successfully extubated. And the key features are the trigger, which is patient initiated, either flow or pressure trigger, and pressure limited, and it is a flow cycle, and it ends when the inspiratory flow falls below the 25 percentage of peak value. And regarding controls, the rate, tidal volume, and inspiratory time are controlled. And ventilator settings, the pressure support level, and PEEP and FiO2 and trigger sensitivity levels are adjusted. And regarding the physiological effects of pressure support ventilation, it decreases the work of breathing, and it improves the tidal volume, and it maintains the patient to ventilator synchrony, and it also decreases the respiratory muscle fatigue. And regarding indications of pressure support ventilation, it is used in a post-operative ventilatory support and then gradual weaning from mechanical ventilation, and also used in non-invasive ventilation and in ICU patients with intact respiratory drive. And regarding the advantages of the PSV mode, it is comfortable for the patient, and there is better synchrony, and there is less need for sedation, and it preserves the respiratory muscle fatigue and activity. And regarding the disadvantages, the tidal volume delivered is variable, and it requires the adequate respiratory drive, and there is a risk of apnea and hypoventilation, and it is not suitable for patients with severe respiratory failure. And contraindications of PSV are severe ARDS or obstructive lung disease, or deep sedation or neuromuscular blockade, and apnea or absent respiratory drive. And regarding complications, there is a risk of hypoventilation and hypercapnia and patient fatigue, and there is also the development of auto-PEEP. That's also.
Very good. So all of you must be familiar with PSP. Most of your anesthesia ventilators also have the option of PSP, isn't it? Pressure support. So at the end of anesthesia, when the patient regains spontaneous ventilation, earlier days we used to take the bag in hand and then assist. Now if you put it on pressure support mode, automatically it will help the patient to breathe on his own and then can give the reversal and come out. So it is used mostly as a method of, initially it was introduced as a method to wean the patient from ventilator and extubate him early. Okay, so spontaneous breathing trials were done using pressure support, and that is the main reason why it became popular. And then the main criteria for using this mode of ventilation is there should be a spontaneous breathing effort from the patient. That is the basic primary thing that you should understand. Then only you can be, your patient should be able to trigger the ventilator. Then the machine will automatically uh, continue with the delivery of gases up to it reaches the particular pressure level, so that the gas will be delivered to the patient. And gradually, once the power becomes more and more, the pressure required will also gradually decrease. So instead of our adjusting the pressure each and every time, machine automatically does all these things and helps the patient to reduce his work of breathing. And that is the reason why we are using this. And only drawback, as you rightly said, is unlike your SAMV mode, that is synchronized intermittent mandatory ventilation mode, there is no machine delivered breath unless the patient initiates his own inspiratory effort. That is the major thing that all of you have to understand. So, unless the patient triggers, takes an inspiration, the machine will not deliver any volume during pressure support ventilation. So, there is no mandatory breath. And so, if the patient is apneic for some time, then no volume will be delivered, and there is a possibility patient will hypoventilate and accumulate carbon dioxide or become hypoxemic. That is the major disadvantage of this particular thing. So it should be used only in patients who have spontaneous effort, and if you understand that, that is more than enough. And I just share the points that you have.